Hello, Assalamu alaikum. This is me, Dr. Jahangir, and you are watching me on my YouTube channel, FCPS Smart Study. Well, the purpose of today's video is to give you the concept of vertigo and dizziness. Most of the time, the patient comes to you in the ER or the OPD, and the complaint is, Doctor साहब मुझे चक्कर आ रहे हैं. Now, what is the definition of चक्कर आ रहे हैं? Most of the time we take that as vertigo. Most of the time we take the meaning of the chakkarana as a vertigo, and the problem is actually not a vertigo. The problem is something else. This is dizziness. So what happens, you treat that patient on vertigo line, and the patient was having problem in the let's for example say the CVS person was having a heart block. Well, I have seen a lot of patients like these, so I thought to give a lecture on that. So patient आता है आपके पास OPD में और कहता है कि मुझे चक्कर आ रहे हैं. तो चक्कर आ रहे हैं या आंखों के सामने अंधेरा आ रहा है, these two are different things. अगर चक्कर आ रहे हैं तो उसमें स्पिनिंग सेंसेशन होती है, आंखों के सामने अंधेरा नहीं आता. पॉइंट नंबर 1. पॉइंट नंबर 2, अगर आंखों के सामने अंधेरा आ रहा है, that is something else, that is dizziness. So you have to differentiate between the two things, whether this is the spinning sensation or it is blackouts, because the management differs. So if that is a spinning sensation, well, I have seen a patient who was complaining of vertigo, and the patient was 78 years old, and she was complaining of vertigo for the last 3 days. She was complaining of vertigo for the last 3 days, and the vertigo that would last for 1 to 3 minutes, and that was not associated with positional changing, because if that is associated with positional changing, your diagnosis should be something else, and that came out to be the TIA. So any vertigo that lasts for minutes, and there is a high risk for stroke or cardiovascular disease, like patient is diabetic, patient is hypertensive, patient is a smoker, patient is having hyperlipidemia, or the patient is having a family history of MI. In male in old age, you should also and always look for TIA. So this patient who was complaining of vertigo was having a TIA. So the patient was started on Loprin. So that is actually a complete different scenario. If a young female comes to you in OPD and complaining of dizziness, and she is having a heavy menstrual periods, you may think of anemia. And hypotension. So the management differs. So you have to differentiate between the two terms. What is vertigo and what is dizziness? Vertigo means the spinning sensation. Dizziness means the blackouts. You are going to black out. In case of a dizziness, the problem is usually hypotension, heart block, cardiovascular system, heart block, heart attack, MI, cardiovascular system. If a spinning sensation, then either the problem is in the brain or the problem is in the internal ear. So you are having a central vertigo and peripheral vertigo. And if you are having both vertigo as well as dizziness, problem is in the brainstem. And this is brainstem stroke or brainstem ischemia. So definition is now clear: vertigo and dizziness. Now, what are the causes of dizziness? The causes of dizziness, mostly think about hypotension. Think about heart block. Hypotension, heart block, these two on the top. So you check the BP and do an ECG. Check the BP and ECG. If in ECG there is a heart block, go on that line. If the BP is low, think about what is the cause of low BP. Whether there is a severe dehydration, vomiting, or diarrhea, you take that history. And also think about other causes of hypotension, generalized hypotension. In a young female, we take the systolic 90 is a borderline. Less than 90 is not acceptable. 90 or more is acceptable in a young female with anemia or even without anemia. So keep that thing in mind. Now coming toward the vertigo, you are having the central vertigo and peripheral vertigo. What is the most common cause of vertigo? The answer is benign positional vertigo, benign paroxysmal positional vertigo. This is the most common cause of vertigo you will see in your wards, you will see in your OPD, and you will see in ER. But if a diabetic patient comes to me, 70 years old, and that is poorly controlled and that is complaining of vertigo, I would be thinking about the TIA first. So we are having central vertigo and peripheral vertigo. In the central vertigo, you are having the vestibulocochlear nucleus in the cerebellum. So you are having, in a central vertigo, you are having the brain stem is involved in central vertigo. In peripheral vertigo, you are having internal ear and vestibular nerve. So problem with the nerve, vestibular neuritis, and problem in the internal ear, such as Meniere disease, and vestibular neuritis, Meniere disease, and benign paroxysmal positional vertigo. In benign paroxysmal positional vertigo, there may be vomiting also. So coming toward these causes, so you are having on the top the Meniere disease. You are having the Meniere disease. In the Meniere disease, the vertigo lasts for minutes to hours. In the Meniere and benign paroxysmal positional vertigo, you are having past history of vertigo. Point number one. Past history of vertigo. Point number one. Point number two. In benign paroxysmal positional vertigo, there are no cochlear symptoms. There are no hearing loss, no tinnitus. In Meniere disease, you can see over here, there are cochlear symptoms. So a patient is having vertigo with cochlear symptom, think about Meniere disease and recurrent episodes. And a patient is having no cochlear symptoms and recurrent episode, but that is triggered by movement. Now this is very important. You are changing the position, sudden position changing. The sudden position changing provoke vertigo and also vomiting in some cases. So this is benign paroxysmal positional vertigo. And again, vertigo lasts for only a few seconds. Now this is very important. This is only seconds and this is minutes to hours. In a Meniere disease, that is for 10 minutes, for 20 minutes, while benign positional vertigo, that is only for seconds. Now this is very important. For 20 seconds, you change the position, there is vertigo, lasts for some time, for some seconds, then it resolves. Then it's benign positional vertigo. From minutes to hours, that is Meniere disease. But along with the Meniere disease, you would expect the cochlear symptoms. Hearing loss and tinnitus. In benign paroxysmal, no hearing loss, but vomiting can occur. Keep this thing in mind. Now, how would you differentiate migraine with vertigo? The answer is severe headache. If a patient is having severe headache and vertigo, so this is basilar migraine. How would you differentiate a TIA? Usually in a TIA, as a cause of vertigo, there is a risk factor. You should address the risk factor: the age, the male sex, the smoking, the hyperlipidemia, hypertension, and diabetes mellitus. If that is there, think about the TIA first. Well, the second thing that is very important with the TIA, you should think about neurological deficit: weakness in the arm, weakness in the tongue, aphasia, and weakness in the eye, diplopia. So you are having diplopia, weakness in the tongue, weakness in the hand or feet. So you should think about in that aspect. You should think about the TIA. Now another is the dizziness. Now I talked about this is persistent postural perceptual dizziness. This is not actually vertigo. This is a sensation of dizziness that lasts for at least 3 months, and dizziness is something else that is related to hypotension. But this thing, you can see, this is very common in our setup. A person is having depression symptoms, a person is having anxiety symptoms and present with vertigo. This is called persistent postural perceptual dizziness. Well, I have seen 2 patients. They have done so much extensive workup in a young female, MRI, CTPA, all the workup. A young female, newly married, for 2 months. She was having some domestic problem. This is actually the patient was having no cochlear symptoms, and when you see the patient, there will be no vertigo. That is a very important thing. There will be no nystagmus. When you see nystagmus, no nystagmus at all, no cochlear symptoms at all, and the patient is having anxiety and depression. So this thing, you will see this thing in your wards, in our society, usually in young female, no risk factors of ischemic heart disease or stroke. So this is called persistent postural perceptual dizziness. This is a sensation of dizziness, not actually vertigo that lasts for at least 3 months, and this is associated with depression or anxiety. Now vestibular neuritis, that is usually viral in origin. There is severe vertigo, short history, no recurrent history for only 1 to 2 days, and symptoms are mild, but vertigo is severe. The nausea is mild, may persist for a week or months. There will be no cochlear symptoms. Now this is very important. In the patient history include recent infection of the upper airway. Now this is very important. A patient is having upper airway infection. Now patient is having vertigo and no recurrent symptoms. So think about vestibular neuritis. So we have covered the peripheral neuritis as well as the two most important causes, the TIA and the migraine of central vertigo. So keep this thing in mind, differentiate between vertigo and dizziness, and differentiate between this is central vertigo or peripheral vertigo. So how do you differentiate between the central vertigo and peripheral vertigo? The peripheral vertigo that is actually horizontal. The central vertigo is usually vertical, but the central vertigo can also present with horizontal nystagmus, but the vertical nystagmus is specific for that. What is the most common cause of central vertigo? The answer is ischemia. The answer is stroke. Brainstem stroke can present with the only vertigo or can be mixed with dizziness. So over here, these are the differences. How can you differentiate between the central and the peripheral? So in the central, you are having CNS involvement. In the peripheral, you are having the inner ear and the nerves. So the associated cerebellar symptoms. Now this is very important. The ataxia and dysmetria, the ataxia especially. In the central vertigo, ataxia is predominant. As compared to the peripheral vertigo, there will be no ataxia. In sense of motion, that is actually severe in peripheral. The associated nystagmus, discussed already, horizontal. Now this is very important. Gaze fixation improves nystagmus. In case of this thing, you can see the gaze fixation. When the person fixes the gaze, that improves peripheral nystagmus, but the gaze fixation worsens nystagmus in case of central. In fact, there is no fixation in case of the central. In peripheral, there is fixation. There is adaptation or fixation, you can say. Hearing loss or tinnitus, that is in peripheral, not central. Focal neurological deficit, I discussed earlier, that is in the central, not peripheral. So the causes, you can see over here, demyelination, the MS. You can see the brainstem ischemia, the cerebellar infarction, posterior fossa tumor, vestibular migraine, and the TIA. This is very important. You have to differentiate the TIA, the stroke, the most common cause, because if you're working in a tertiary care, the patient land there in a very later stages of the disease. For peripheral vertigo, they have taken the treatment from the outside. So far from the peripheral, mania, benign paroxysmal otitis media, the acoustic neuroma, and the vestibular neuritis. These are the most common causes of the peripheral vertigo. Well, the purpose of today's lecture was to differentiate between the vertigo and the dizziness. What is the difference between the two? What are the causes of these two, and how would you manage these two cases? The basic purpose was not to mess the stroke, not to mess the TIA, not to mess the stroke, not to mess the TIA. Who present to your ER is a case of vertigo, is a predominant symptom of stroke. Thank you for watching. Well, press the bell icon and share my video so that press the bell icon so that you can get the notification of my new video. Thank you for watching.